All right, guys, thank you for having me. I appreciate it. The name of my talk is Sports Injury, Should You Tough It Out? And let's see if that works. All right, who am I? So thank you for the introduction. So this is a little bit about my education. So I went to Notre Dame for undergraduate, and then I was at Temple University School of Medicine for medical school. And then I did my residency in the city, what's Mount Sinai, St. Luke's Roosevelt. Oh, is it?
Yeah, now you're
Hello?
good. You're good. You can keep
Okay,
talking.
and then, so I continued my training and fellowship in California at the University of Southern California, where I worked closely with the athletic teams, the football team, the soccer team, the basketball team. So, and then I moved back east, and so now I'm here at Ridgewood Orthopedic Group and Valley Hospital, board certified, and I'm licensed here in New York and New Jersey. So, so first we'll start off with what is an orthopedic surgeon. So, contrary to some belief, it's not teeth or the feet. So what orthopedic surgeons do is we're specializing in surgical and non-surgical treatments of disorders of the spine, joints, muscles, ligaments, and tendons of the body. Some of our subspecialties are spine, joint replacements, hand, foot and ankle, pediatrics, trauma, and sports medicine, which is a lot of what I focus on. This is my group. So we have a fairly large size group. These are our surgeons. So Dr. Delfico, Dr. Costello, who's spine surgery. We have some joint surgeons, Dr. Pizzoro, Dr. Zarevich. Dr. Brief is our foot and ankle. Dr. Rombach is hand surgery. And Dr. Dosti and I are sports medicine. And Dr. Amorosa is spine and trauma. Dr. Terranova is our physiatrist and rehabilitation medicine physician. So my practice is split, often in the office, and I also operate in surgery. And that's a picture of me getting ready for the OR. And then I cover the emergency room at Valley Hospital. These are some of the surgeries I perform. Sports medicine, as I said, is my focus. A lot of arthroscopic, minimally invasive surgery, the shoulder, the hip, the knee, including the shoulders, rotator cuff repairs. I do shoulder replacement, ACL reconstruction, and cartilage and meniscus surgery of the knee, as well as fracture work, trauma work as well. So getting back to this lecture, so some of the things that we're going to talk about today is basically based on, if you want to tough it out, what exactly do you want to do? How long do you want to do it for? How do you maintain these goals? How do you prevent injury? So there's no need to actually tough it out. And then if you do have an injury or a setback, how do orthopedic surgeons, how do we help you so that you can get back to doing what you want to do? Okay, so we'll start with what do you want to do? I just went through some basic, do you want to play baseball, golf, skiing, running, just work around the house, playing sports with your kids. So your goal is important as far as what we're going to do and how things are being treated. It's how aggressive we are, whether we're going to do conservative care, whether we're going to operate. These are all important for sort of deciding your life goals. So how long do you want to do it for? And basically what we're finding out is that we're all living a lot longer. And so we need to plan accordingly that, we need to preserve our body at a younger age so that as we get older, things don't break down. So life expectancy is going up. Actually, I think with COVID as the first last year or two was the first year maybe dipped a bit, but in general, the average life expectancy is about 78, 79. And once we get to 65, it's even longer. So the average person who gets to 65 lives into their mid 80s. So how do you maintain these goals? And a lot of this is based on prevention, and I'll kind of get into what that means. So there are a number of different ways to sort of prevent injury. Aerobic conditioning, strength and endurance, flexibility, balance, and early intervention. And so aerobic conditioning, some examples of this are walking, running, biking, swimming, skiing. Flexibility helps you perform the activities better. Again, as I said before, it helps you avoid injuries. So warming up and stretching are very important, and some different principles of stretching. Basically, you're not trying to push through pain when you're stretching. A little discomfort, a little pulling, that's what you're going for, but frank pain is to be avoided. 30 seconds is a reasonable amount of time to stretch. Relax into the stretch, deep breathing, you don't want to hold your breath, and avoid sort of a bouncing, jerking type motion. That's not what you want to do. So warming up's important, things like marching, walking in place, jumping jacks, and basically you're trying to mimic the sport you're planning on doing, but at a lower pace. Strength and endurance is also important as part of the overall prevention method. Work on your cardiovascular system. Strength training exercise also increases flexibility, strengthen your muscles, your bones, and helps with body fat. So every other day is a fair amount of time if you're able to do it. Even 20 to 30 minutes, a short amount of time is fine. Short rest periods, and you're trying to fatigue your muscles. Balance is also very important for preventing injury and also for falls. Some exercises that help with balance activities are yoga, Pilates, things like Tai Chi, shadowboxing, and those exercises are very good for that. So cross training is important. So combining the aerobics, combining the strength training, combining endurance, flexibility, all of these sort of lend to a well-rounded program and sort of can help you prevent from being bored, hitting a plateau. And then a lot of the injuries I'm going to talk about later are sort of overuse type injuries. So by doing the cross training, you can prevent a lot of those. So, all right. And then sometimes injuries do happen, and that's what we're here for. So I'll kind of get in. And other times, I don't know if this is going to work. So that's my 1-year-old skiing. So I don't know, just pick up. We try that. And there we go. So when you do suffer a setback, how can we help you? And I'm going to talk about some common injuries, and then what they are, and then can you treat those, how you treat those, and when do you need to go to your orthopedic surgeon. So these are some of the common ones we're going to talk about today. So ankle sprains, plantar fasciitis, tennis elbow, stress fractures, neck and back injuries, shoulder injuries, and knee injuries. So ankle sprain. So what is an ankle sprain? So it's a ligamentous type injury. So it's typically when you roll your ankle in and then you either stretch or partially tear the ligaments on the outside of your ankle. It presents with ankle pain, tenderness, swelling, and so I'll kind of get into some of the treatments next. So how do you treat an ankle sprain? The simple acronym is RICE, which basically means rest, ice, compression, elevation, rehabilitation, strengthening exercises, anti-inflammatories. Bracing can help sort of supplement the treatment. So when you get back to exercise, it can give you a little extra stability, but basically you're waiting for the initial injury to sort of calm down and relax and help with the anti-inflammatories and the icing. And then you work on sort of getting the range of motion back, getting the strength back. And so many times this is something that either can be dealt with time and conservative care or physical therapy. Occasionally with repeated ankle sprains, these are treated with surgery, but by and large, ankle sprains are something that can be treated with conservative care. So next, we're going to go to plantar fasciitis, which is very common. It's sort of, the plantar fascia is basically this band of tissue that connects the base of your toes to your heel. Most commonly, this is presents as pain at the base of your heel. It is often an overuse. For example, if someone was to gain a significant amount of weight and try to rush into a heavy running program, those types of things can cause inflammation of the plantar fascia and sort of these micro tears, and it's very painful. And so we'll talk about what that means. So some of the treatments for plantar fasciitis, there's custom orthotics, stretching, and stretching is the most important thing. There's several different stretching exercises, and those are very, very important. And sort of the core to improving plantar fasciitis is really diligent stretching. And so that's something that work can really help with. Work and rehabilitation, whether it's on your own or whether it's with therapy. So stretching exercises, night splinting is another modality. So what tends to happen is the plantar fascia contracts at night. And then if you keep your foot in an extended position so that it can't contract, it helps with that plantar fasciitis, and it helps that plantar fascia heal. And then ice and anti-inflammatories, massage, those are other sort of components of the whole treatment. And then, if that's not working, there are other sort of options as far as seeing an orthopedic surgeon, a foot and ankle surgeon. But by and large, these are sort of conservative things that can be treated. Yes. It's keeping your foot out of flexion. So you're trying to keep your ankle at essentially a 90-degree angle. Yes, yes, exactly right. Exactly right. So, another common injury, another common pain generator is tennis elbow. Basically what tennis elbow is, kind of go to the next slide. Tennis elbow, there's a lateral protuberance sort of on the side of your elbow. It's called your lateral epicondyle. And there's the common tendon that extends your wrist. And so all of these muscles, tendon unit that attach on the side of your elbow can become inflamed or become partially torn. And so this is something that it happens with tennis and with repetitive overuse type injuries in sports such as tennis, but also just day-to-day life. So many people who present to our office just have this tennis elbow type epicondylitis type pain. And so this is something that we treat very often. And then this is sort of, on the contrary, is medial epicondylitis, which is on the inside of the elbow. And it's this overuse or partial tear of the common flexor tendon of the elbow. And so that's something we see very often and something that can be dealt with both at home or by seeing your orthopedic surgeon. So I will kind of go into some treatments. The core tenet of tennis elbow treatment or golfer's elbow treatment, which is the tendon on the other side of the elbow, is really an exercise program. And those exercises are working on strengthening the muscles in your forearm, stretching those tendons, stretching those muscle tendon units. And so whether we give you an exercise program to work on at home or whether you go to therapy, that can be very helpful as part of the overall treatment for tennis elbow. And then after that, there's different types of bracing you can do. Sometimes the most common is the counterforce strap, which is basically a strap that provides some compression. You put it on your forearm, and it combines with the overall treatment modalities we have, and then ice, heat can be part of it. And then from there, we go to injections. And so cortisone can be very helpful. There's another injection called PRP, which is basically where we take your blood and we spin down the plasma. So and basically take out the inflammatory properties of your blood and help sort of heal that epicondylitis, that tendon injury. So, and then from there, sometimes these go on to surgery. Many times they don't, but that's certainly an option as well. Then we go on to stress fractures. So stress fractures are injuries, and basically you can think of them as micro cracks. They're not, they're very tiny cracks in the bone. They typically affect the ankles and the feet. They're usually from a repetitive overload, really overdoing it. A lot of times we see these runners who maybe aren't resting as much as they should or are pushing it past where they can. So this is something that it's not as sudden and severe as a traumatic type fracture, but it comes on a bit more slowly. Oftentimes they're treated with things such as boots, and many times they don't require any kind of surgery or casting, but these are something that you don't want to ignore and that you do want to be evaluated for. Sometimes they show up on x-ray, and sometimes there's more advanced imaging that we can take a look at and see if there's a stress fracture. So this, yes. Sometimes they do, sometimes they don't. So it depends on really the evaluating physician needs to have a suspicion, and sometimes we can see them on x-ray, but if there's a strong suspicion, often we'll get further imaging such as an MRI, and that will more clearly show it. You can also see edema, or you can also see basically inflammation in the bone, and that will show up on MRI. But yes, MRI is very good for seeing soft tissue. It depends on the type. 6 weeks is a general time frame that give or take 6 weeks. But it depends on how it's treated. But in general, bone stress fractures do take about 6 weeks. They take a long time. You can usually, so often we treat those in a cam boot or a boot to help immobilize it. It depends on the type of stress fracture, but yes, often you can weight bear on them. Carpal tunnel is another very common issue that we find. And basically, what is carpal tunnel? Carpal tunnel is compression of the median nerve. So the nerve that basically runs in the front of the forearm and the wrist, and it gives us sensation and provides some dexterity in the fingers. And so typically what happens is it's an overuse type, repetitive overuse, job-related injury, and we get this pain and tingling in our fingers. Sometimes we get clumsiness in our fingers. Sometimes there's numbness. It's not always job-related. It's very common, but it can be evaluated based on clinical examination. There are also tests such as an EMG test, which does test the nerve for compression. But these are the types of symptoms you can look for. And let's kind of talk about the treatment options. So when we see carpal tunnel, splinting can often be helpful, particularly at night. Sometimes we do injection into the area where the nerve runs. And so that can help calm some inflammation of the surrounding tendon units and the nerve. Anti-inflammatories can help. And then lastly, if that doesn't work, sometimes we do a surgery, which is a fairly mild surgery where you basically go in and you release the band of tissue that covers the nerve, and that can help give it more room to function, and so that will relieve those symptoms. Next, we'll talk about some neck and back issues. The neck and back. So anyone you meet, either themselves or someone they know, has a neck and back related issue. So the vast majority of these are muscle related. So they're muscle spasm, muscle pain, but there are other types of neck and back related issues that are more concerning. And so the things that we really look for are, do you have weakness? Do you have numbness? Do you have more of a radiating pain? For example, pain that radiates down your leg. Those are more concerning symptoms as opposed to just more muscular low back pain, because that's a very common issue. And so here I try to show on the bottom, those are, there's many different muscles that are related to your neck and back. Some of the things we also look at are these disc herniations, where you can have basically a disc between the bones in your back that pinches a nerve. You can get arthritis in the back, but those are some things we look for. So, all right, so often the initial approach when we look at neck and back pain is with an X-ray. More specifically, as you mentioned, MRI will look at the soft tissue, so it'll look at the nerves, it'll look at the discs, but those are sort of, whether you need an MRI is often decided by a specialist, and so that would be a reason why you can potentially come in and not just tough out neck and back pain. Key treatment options for neck and back related pain, as we discussed before, stretching is very important, stretching your hamstrings, stretching and strengthening your core, physical therapy to help with that. Anti-inflammatories can help. Sometimes we go on, and particularly if you have inflammation around a nerve, sometimes we can do a cortisone injection. And then the last option would be a surgery, whether it's a clean out type surgery or whether it's a fusion type surgery. And so that's kind of down there on the bottom right. All right, shoulder. So shoulder is part of what I specialize in. And so we'll kind of talk about that, but there's many shoulder related injuries. So these are, the rotator cuff tendons are very commonly affected, and I'll kind of go into that. So what are the common shoulder conditions? Basically bursitis, which is inflammation of the bursal sac, or you can think of it as the cushion around the rotator cuff, and that goes along with impingement syndrome. And then there's rotator cuff tendonitis, which is inflammation of the rotator cuff tendons, which are the muscle and tendon units that move the shoulder. Biceps tendonitis. The biceps tendon is basically one of part of your biceps, and that courses through the shoulder. It can often become inflamed or torn. Dislocations of the shoulder are very common, and when you have a dislocation, you tear the labrum, which is the structure that helps support your shoulder. Fractures of the shoulder are very common. Rotator cuff tears are sort of the progression of bursitis or rotator cuff tendonitis, and then arthritis will be the last one that we look at. Yes. Yes. So there are 4 different rotator cuff tendons, and they're all here. So this is the supraspinatus, which is the most commonly affected rotator cuff tendon, and that's the one that lifts your arm up, that forward elevates your arm. The infraspinatus is here, and that's the one that basically the infraspinatus and the teres minor, which is also here, help rotate your arm. Those are in the back, yeah. So this is looking at the back of your shoulder. And then this is actually, if you look here, this is the subscapularis, which is the 4th rotator cuff tendon, and that's in the front of your shoulder. So so the picture on the left is looking at it from the back, and the picture on the right is from the front.
When you hear an athlete tearing his rotator cuff,
It's primarily supraspinatus. Second most commonly would be the infra, and then the subscapularis after that. The infraspinatus also is commonly torn, and the subscapularis. It's typically those three tendons that are torn. There's yeah, yes, yeah. So when deciding basically whether you need to present to the physician or whether you can sort of manage these at home, there's important history facts that are contribute to whether you can sort of tough it out, do the therapy aspect, or come in to see us. And realistically, one of the things that's important is, did you have a frank injury? If there was a traumatic injury, it's more important to sort of be evaluated acutely or as soon as you can. Where does it hurt? What part of your shoulder? How long? If it's a couple of days of shoulder pain and it's more mild, maybe it'll sort of improve over time. Do you have weakness? Weakness is a more concerning sign. Is there a tendon rupture? Is there a tendon tear? And then, do you have pain at night? Is it keeping you up? Is it disrupting your life? And do anti-inflammatories help? Careful examination is important, and that's kind of what we do. And even Putin needs to be examined every now and then. So our approach to diagnosis, x-rays are important. When you see the x-rays, if someone doesn't have arthritis, that kind of leads you down one way, or someone doesn't have a fracture. So x-rays are very important as part of the overall approach to shoulder issues. As mentioned before, MRI is the more advanced imaging, and that is better for looking at the tendons, the muscles, the cartilage. So when we start having more concern, we kind of often jump to an MRI as part of our treatment options. So in general, approach to treatment, modalities such as ice and heat, massage, electrical stimulation, anti-inflammatories, physical therapy, injections, and surgery. And I'll sort of go into each different shoulder condition and kind of talk about which one of those is appropriate or which few of those are appropriate. So we'll start with bursitis, and bursitis is very, very common, and it's inflammation of that bursal sac, around the rotator cuff, and it's kind of in that realm of what we call impingement. It often leads to rotator cuff tears, and so it's often the first sort of sign before rotator cuff tear happens. And then if rotator cuff tears are ignored, often it can progress to arthritis. So I'll sort of talk about that bursitis first, and it's also known as impingement. When you see on the x-ray, there's basically a bone spur here. And so every time you lift your arm, basically that bone spur can rub on the tendon, can rub on that bursa and cause inflammation in your shoulder. This is very common. It occurs at any age, but more commonly in older people. Usually it's an overuse type injury. Pain when you lift your arm to the side or towards the front. You can often get pain at night with this. And that's bursitis. Treated with anti-inflammatories, again, heat and ice, physical therapy and home exercise, and that's important. Basically, you want to work on building the strength of your shoulders, of the muscle that connect your shoulders to your neck, your back muscles, get better posture, strengthen the rotator cuff, and that can often help with bursitis. So doing the work, putting the time into physical therapy and exercise does often work for bursitis-related pain. The next step up would be cortisone injection, and that's very common for bursitis pain. And the last option is surgery. And so if you see basically in that picture on the left, there's a bone spur. And so what we do is basically we clean that bone spur down so to make a nice flat surface. So when you lift your arm, that bone spur doesn't rub on the bursal sac, it doesn't rub on the rotator cuff. So this is another option if things aren't improving with the conservative type treatments. That's the acromion. That's the front of the acromion, which is the bone right. If you push on the front, sort of the front outside of your shoulder, it's that bone right there. So rotator cuff tendonitis, they go hand in hand. They're very similar treatments, but rotator cuff tendonitis can often go on to a tear as well. So bicep tendonitis. The bicep tendon, as I discussed before, it runs right through the shoulder. So you can see that tendon right here. And I'll kind of show you what it looks like. So it courses to the shoulder. It's very easily inflamed or partially torn. And so this is a tendon, what it looks like in surgery when basically you have partial tearing of that tendon. And often what we do when you have that, so the conservative way to treat biceps tendonitis is basically therapy can help, anti-inflammatories can help, cortisone injections can help, and then the last option is surgical. And basically we take that tendon and we route it so it doesn't run to the shoulder anymore, and it's a very successful surgery. So, yep. So the biceps tendon actually attaches on the top, on the top of the glenoid.
Where is that?
So the glenoid is here. So the glenoid, so the labrum, you can usually, you may be thinking of the labrum, which is basically the cartilage structure around the glenoid. Or you can get arthritis of the glenoid. So so where the biceps attaches, they often
Screw something in there?
typically the screw is on the humeral side. So you take the biceps tendon and then you reroute it off of the glenoid onto the base of the groove on the ball side of the shoulder. This is can you see my, yeah, this is basically the tendon typically attaches here and then it courses through the shoulder. And so what you do is you basically reroute it so that it attaches now a little further down in the shoulder on the sort of in the groove here on the humeral head, which is this ball here. And so
that piece,
yes.
that's what,
So that piece, so this bit, they're just typically during surgery, you basically remove that piece and they're just showing you that so you can kind of see where the tendon initially was originating from and then now where it's being moved to. Yep.
So if there is a tear, it's possible it will heal without surgery, with therapy, physical therapy?
It doesn't necessarily heal per se, but it can become so it's not painful. So if you have a tear in the bicep tendon, many times people live with bicep tendon tears or partial tears for a long period of time. And it's not painful. Not always, but often you can start with a biceps tear. And if it progresses and the tendon completely ruptures, completely tears, often what happens is something known as a Popeye deformity. So your biceps muscle will clump and it'll spasm and it'll be painful. And it's typically for several weeks, a month or two, and then often it gets better. And so even a biceps rupture, there's two tendons in the biceps. And so even if the one that basically courses to the shoulder is torn, you can still maintain good elbow flexion strength, good function. Any questions?
A couple questions here.
Okay.
Shoulder being one of your specialties, what are your thoughts on overhead activities in the gym, such as shoulder press?
So shoulder press is one of my least favorite shoulder strengthening exercises. Shoulder press, particularly with the bar, tends to stress and aggravate the shoulder. And so if your shoulder, particularly if your shoulder is painful, that's really one of the last exercises I would try to participate in. There's other ways that what you're trying to do with overhead shoulder type press is you're basically trying to strengthen your deltoid muscles, which is that big fat muscle on the side of your shoulder. And there's other ways of doing that, such as forward raises, some side raises sometimes are a little bit better tolerated, but the whole overhead strengthening, it can be tough on the shoulder and on the biceps as well, frankly.
Are there any biological treatments for arthritis besides arthroplasty?
So what we also, the PRP, which is that platelet-rich plasma, is basically where we take your blood and we basically spin down your own basically growth factors to try to calm, or anti-inflammatory factors to try to calm your arthritis process. And we've shown that that works. Unfortunately, that is not, the insurance hasn't really caught up with that yet. So I think that will be in the future. Stem cells haven't really been borne out in the literature, so they haven't really been proven to work as well. But the PRP, or the platelet-rich plasma, is promising for sure. So, and then the other thing that people often talk about are the gel injections, but they're not approved for the shoulder. So, all right. So next we're going to go on to dislocations, which is kind of along the labral tear issue. So dislocations, basically when the ball and socket joint is dislocated, typically this goes on to popping your shoulder back in place, whether that's done, sometimes people do it on their own, often it's done in the emergency room. When you dislocate your shoulder, you typically tear the labrum. That is the cartilage structure that basically supports your shoulder. And so the way labral tears are treated, kind of going to the next slide, often the first dislocation is treated without surgery. So with a short period of mobilization, so a short period of sling, typically a couple weeks, and then gradual return to exercise activity. Often physical therapy is utilized. If someone is having more than one dislocation or several dislocations, typically the more you have, the more likely you are to dislocate. So once we start having multiple dislocations, those are typically treated with surgery. Note that surgery is sort of shown here in the picture. It uses these anchors and the suture to sort of repair the labrum back where it needs to be. Exactly right. There's many ways of getting stability of the shoulder. There's bony stability, which is what we talked about before, which is the ball and socket joint. The labrum also helps give it extra surface area, as you said. And then there's basically the rotator cuff and the deltoid, the different muscle tendon units that help support the shoulder as well. Different fractures of the shoulder, and I'll sort of touch on some of these. So clavicle fractures are very, very common. In many people, in children, and more elderly people, these are treated without surgery. Classically, most of these are treated without surgery. So you really can't put weight on them. You're in a sling for somewhere in the range of 2 to 4 weeks, and then we sort of progress and get back to normal function. In younger, more active patients, particularly when the bones are more displaced or further apart, we fix these with surgery. So we'll talk about different fractures of the proximal humerus. So basically, kind of show those are some of the different ones, but I'm going to get into them more. These are the third most common fracture in elderly people. Very common fractures, 5% of all fractures, and the majority of fractures of that humerus bone, of the bone in your upper arm, are proximal humerus fractures. The mechanism is typically a fall into your shoulder, and then many of these are treated either without surgery or with surgery. And there's many different fracture types, and so I'll kind of get into a bit of which ones we fix without surgery and which ones we fix with surgery. It's important of what part of the bone is fractured, how old the person is it their dominant arm, how functional, do they want to get back to pitching, how healthy is the person, but there's many different factors that are involved in these types of fractures. And so if we do operate or we do go on to surgery, what exactly do we do? And some of them are easy. So for example, someone is in their 80s, the fracture here is pretty well aligned. Maybe there's a component of health isn't perfect, or there's some dementia. Then typically we treat these without surgery, and many people can go on and heal without surgery and do very well. Maybe a younger patient, mother works as a nurse, is their dominant arm, the bones are not aligned. Often we fix this with a plate and screws, and that would be sort of the next option. And then there's the other way to treat this. So 75-year-old female, healthy, this is her dominant arm, lives alone, so really has to take care of herself, watches grandkids, very active. So when there's many fragments of the bone, often these don't heal when you fix them. So what we do is we often do a shoulder replacement. And this is a very successful surgery for this type of fracture. It allows pretty good function, good range of motion. And so that's sort of our last option for these types of fractures. And there's many, yes. Most of the time you're in a sling for about 4 weeks, maybe getting the range of motion back takes 2 to 3 months. And then total time is about 4 to 6 months to get the strength back. All of these fractures though, they're tough. You know, it takes a lot of work, time, therapy to sort of get your function, get your range of motion, your strength back. So even without surgery, these are all months. So don't fall, but I don't know how possible that is. All right. Rotator cuff tears. So these are also very common. Again, these are some of the pictures of the different tendons, and I'm kind of going there. So when people think of rotator cuff tears, often there's an injury, but often there's not. Often it's just the rotator cuff tends to wear over time. As we age, our rotator cuff wears out, and so many people as we get into our 70s and our 80s, our 90s, have rotator cuff tears, even if they are not particularly painful. It tends to be pain over the top and the side of the shoulder, difficulty with elevating the arm. You can get some weakness, pain at night. MRI is really the best modality to sort of see if you have a rotator cuff tear. Occasionally it's done on ultrasound, but really MRI is the gold standard. Treatment is dependent upon how new the tear is, the size of the tear, what the person is trying to get back to or what their expectations are. Many tears are small and can initially be treated without surgery. Physical therapy we discussed, injections for pain, but those don't really repair the tendon. Once the tendon is detached from the bone, it doesn't really heal itself. So surgery is really the option for that. Rotator cuff tears. So typically these are done through the camera through arthroscopic surgery. And this is an example of what it looks like. So basically we use these very high strength anchors and with sutures attached to them, and then we repair the tendon back to the bone. And it's a similar type of rehab. Typically we're in a sling. I'll kind of go to the next slide. Yes.
They don't have surgery, so basically the tear stays there?
The tear, yes, the tear typically does not heal itself.
So you need to strengthen the muscle?
So you're strengthening the surrounding muscles. So for example, this big muscle here that we talked about before, the deltoid, that's still functional, and you can you can strengthen this big muscle here and sort of compensate for a torn rotator cuff. Not always, but by building that strength up, often you can get reasonable function. So rotator cuff surgery is typically same-day surgery. You're in and out in an outpatient type setting. Sling, depending upon the size of the tear and the surgeon, is typically for 2 to 4 weeks. And then this is, again, a 3 to 6 month therapy, and it definitely takes work. I mean, it's not something where it just resolves over time. You need to go to therapy, you need to work on exercises in order to do well with this type of surgery. The last thing we're going to talk about is arthritis. And typically arthritis is age-related, wear and tear. Sometimes there's a history of trauma in the past. There's genetics component to it. And typically arthritis presents with pain and stiffness. So someone comes in, they have significant pain, there's losing motion over years. That sort of clues us in that they may have arthritis of the shoulder. Usually we don't, there's many times when the answer is always MRI, but that's not always the case. The diagnosis for arthritis really just needs an x-ray and good exam, history. So x-rays are very important for shoulder arthritis. Shoulder arthritis is also treated with anti-inflammatories, physical therapy, injections, and then the last option is surgery. This is kind of what it looks like. So if you look at the picture on the left, there's a nice contour to the bone here. There's a space between the bones, which is where that cartilage is, where that cushion is. And so that clues us in there's no arthritis. And then when you look at the picture on the right, it's pretty clear. So you can see that there's deformity of the ball, of the humeral head. There's a bone spur here. That space is completely gone. And now that we talk about bone-on-bone arthritis, that's what this is.
So space is now occupied with
The space, well, there are bone spurs there, but the space basically has worn away. What you don't see on x-rays is you don't see the cartilage. And the cartilage basically allows for that space to be there. And so when that space is gone, it becomes bone-on-bone arthritis.
do you have any
What's that?
those two, the bones, I guess, scapulary and the humeral head, if they use from where there's no soft tissue?
They typically don't completely fuse, but it can very much restrict your motion. So, and when you do have shoulder arthritis, this is what a shoulder replacement looks like. And we've tried to sort of minimize the implants so they're very small. This is basically a cap that takes off as minimal amount of bone as possible. And what we found is as people are living longer, sometimes these implants wear out. And so we try to sort of preserve as much of your bone, as much as what you have as you can. And then we basically put in these small implants. And that's what a shoulder replacement, or one of these shoulder replacement looks like these days. We don't have a set, I wouldn't say we have a set number. So it depends. It depends on the person. It depends on the functional level, how much they're restricting. It's a work in progress. And this is sort of gives you an idea. There's two different types of replacements, and there's the standard ball and socket joint on the left, And then when the rotator cuff, when there's a process of arthritis as well as a rotator cuff tear, we often use the implant here on the right, and that's a reverse shoulder replacement. Basically what that does is it changes the way the center of rotation of the shoulder, and it basically compensates for your rotator cuff and allows, again, this big muscle here, the deltoid, to function to lift your arm. So when there's a big rotator cuff tear, when there's arthritis, we tend to go to the reverse replacement. When there's intact rotator cuff and arthritis, we typically do a standard shoulder replacement. So we'll finish up with the knee, and I'll kind of go over some of the more common things with the knee. The most common is the meniscus tear. The meniscus basically helps the knee joint carry weight, glide, and turn. Often we can tear the meniscus with a twisting type injury, common in football and other contact type sports. But often, this can be, the meniscus can tear as part of the arthritis type process as well. So meniscus tears, typical symptoms of meniscus pain giving way, which is also buckling of the knee, locking type symptoms, clicking, swelling. Those are all symptoms that we look for. The meniscus it's the C-shaped structure, and you can see it. Basically, you have one on the inside of your knee and the outside of your knee, and basically you're seeing it between the bones on the picture on the left. You're seeing it sort of between the femur bone, which is that bone in your thigh, and the tibia bone, which is the bone in your lower leg and your shin. And it's not a good view. And then here, these are the two meniscus as well. So this is the lateral meniscus, and this is the medial meniscus here. No, they're separate C-shaped structures. So, and commonly they tear in the back. So many people who have meniscus-related pain have pain in the back of the knee. So it's a very common presentation in the office. Yes.
What do you think of the over-the-counter med called glucosamine?
So the evidence for both, chondroitin and glucosamine are the over-the-counter medications, but the evidence hasn't really borne out that they work well or realistically work at all. So typically my answer is I'm okay with, as long as it's purchased from a reputable source, I'm okay with it, but the evidence that it works well hasn't really borne out. So I typically don't recommend, I don't encourage glucosamine and chondroitin. So when we get into meniscus tears, basically the treatment is either conservative, similar things we've talked about in the past, the physical therapy, sometimes cortisone injections, and many people live their lives with meniscus tears and they aren't painful. And so just because you have a meniscus tear does not mean you need surgery, but often these are treated with surgery. So particularly if you have some of those symptoms we talked about, such as catching or buckling or locking of the knee, those are more concerning. And then we go on, and there's two main types of surgery we do with the meniscus tears. The bottom pictures are clean out type surgery. And so we basically take that tear and we just clean out what's non-functional, what's not torn, and we leave the residual meniscus that's still functioning. And that's known as a meniscectomy or a clean out surgery. In the top is a picture of a repair. So in particularly younger patients or certain tear patterns, we can actually fix the meniscus. And there's been a push to do that as much as we can, as we've learned just how important the meniscus is to sort of prevent arthritis and other functions in the knee. And so we've tried to sort of make a push when appropriate to fix the meniscus as well. ACL injuries are the next, and they're very common. It can be a blow to the knee, but more commonly it's actually a non-contact type injury. Football, soccer is very common. Skiing, it can happen. Landing on a straight leg and making abrupt stops. With ACL injuries, this is definitely one where people don't just tough it out. I mean, these are painful, they're swollen. They often initially feel tight because of the swelling, but then they go on to feel loose, to feel unstable. So people come with ACL injuries, and this is often diagnosed on an MRI as opposed to an X-ray. And then we'll kind of go on from there. Many people go on to fix their ACLs, particularly young athletes or younger people. This is also an arthroscopic type surgery. We've done this, we've sort of made progress and advances with ACL reconstruction. It's more minimally invasive. And that's kind of where we go from there. But not everyone needs an ACL surgery. So many people live their lives without an ACL, particularly if you're more focused on doing sort of straight line exercise. It's the pivoting that tends to be difficult. Playing tennis, playing soccer, those things are very difficult without an ACL. And so many people, especially younger patients, again, tend to fix their ACLs. And when I say fix, it's more of a reconstruction. So taking a ligament from a different part of your knee, taking a tendon from a different part of your knee, and then making that ACL ligament. So the meniscus is here. Yes, these are the meniscus here. Yes. Yes. So these are the condyles, are basically they're part of the femur bone, and so you can see the one here and then the other one here, and they're separate. And then we go into knee arthritis, and so knee arthritis is often something we can quote unquote tough out. Knee arthritis is treated. When I talked about, I'll kind of go to the next slide. When I talked about the gel, which is also called hyaluronic acid, is the medical word for it. Basically, your cartilage is made out of hyaluronic acid. It's either made from the back of a rooster comb. That was initially where it was taken from. More commonly now, it's actually made in the lab, but that can contribute to helping with pain in knee arthritis. It doesn't regenerate the cartilage. Once the cartilage is gone, it's typically gone. Steroids can help. The PRP we talked about before can help. And then the last option for knee arthritis is a replacement. And knee replacements are very common when those other modalities don't work, when your life is affected, particularly, if you can't do the things you need to do, if you can't walk, knee replacement is definitely a reasonable option. So key points, basically be smart when you're being active. Warming up and stretching is important. You want to gradually increase your intensity and duration so things like stress fractures don't happen. Be prepared to sort of take a break. You don't want to really push through pain. Know when and where to seek help. And many conditions are easier to treat the sooner you go after them. So that's myself and Dr. Zdarovich and our kids. And we went on a ski trip, and he sustained that injury, but he was good after that. So that's pretty much it. All right.
I do have one question that has come in. How about the inverse of toughing it out? How does an athlete know when they can return to a high level of performance after a serious injury?
Okay, sorry, repeat the question.
Yep. How does an athlete know when they can return to a high level of performance after a serious injury?
Well, basically there's return to sport protocols. So typically with a physical therapist, with an athletic trainer, with an orthopedic surgeon, there's different steps that you have to sort of meet. For example, after an ACL, there's each few weeks or each month, there's a stepwise progression to get back to your sport. So it depends on the injury, but that's why there's sort of there's a team that sort of helps, as opposed to just being the therapist or the trainer or the surgeon. Everyone sort of contributes so that you're meeting the landmarks so you can get back to your sport as you would like.
And I have one more.
Yep.
What if, hold on. Another one that came in, now that one went away.
So I've been in practice for 5 years. So it's 5 years residency, year fellowship, and my 5th year in practice.
So once you went to medical school, you did 6 years?
Yeah, so after medical school, it was another 6 years of training, and then I've been in practice for 5 years after that. Yeah, so I've been as a doctor, is my 11th year as a doctor. So it's a longer run.
What if rotator cuff tear is severe and can't be repaired?
So if it can't be repaired, that's when there are some other things I didn't really get into as much, but there are also grafts that we sometimes use. And so if you can't repair your rotator cuff and you're not ready for a replacement, sometimes we basically do what's called a superior capsule reconstruction, which is where we use a graft. It doesn't function quite like your rotator cuff, but it can sort of bridge and help with shoulder pain and sometimes function until the replacement is more appropriate.
And one more. In general, when do you use heat versus ice for treatment?
It depends on the situation. So ice helps with inflammation, and so with more of an acute, I sprained my ankle and now it's swollen, ice is more helpful. I'm always okay with heat though. So if heat is helping with pain, heat sort of helps bring in blood flow. Heat can contribute as well. Many times they're both important.
I have a quick question.
Yes.
It's a shoulder condition that I didn't see on the list. It's frozen shoulder.
Yes.
Talk about that a little bit.
So frozen shoulder is basically inflammation of the capsule around your shoulder. It's more common. Some of the risk factors are thyroid issues or diabetes. Basically frozen shoulder, there's usually not a traumatic injury and your shoulder becomes stiff and painful, and it's often very painful. But the treatment for frozen shoulder is typically anti-inflammatories, cortisone injection, and therapy, whether it's exercise at home or physical therapy. As a last resort, sometimes we go in with the camera and we sort of clean out that scar tissue, but often it's treated without surgery. So it depends how long it's going on. Again, anti-inflammatories, injection therapy.